Coronary heart disease remains the leading cause of death in the United States. Approximately 1 million myocardial infarctions occur per year in this country. Of these, only about 50% survive to reach medical attention. Given the large volume of patients who suffer from coronary heart disease and the huge threat posed by myocardial infarction, it is of utmost importance that cardiologists be thoroughly familiar with the full range of applications of 2D and Doppler in the assessment and management of patients with coronary heart disease. In this tape, we will first discuss the echocardiographic techniques for assessment of left ventricular global and regional function. Next, we will discuss utilization of echo in the setting of myocardial infarction, including acute and chronic complications. We will then discuss echocardiographic visualization of the coronary arteries, and we will conclude with detection of ischemia via exercise echo. In ischemic heart disease, the most potent prognostic factor is the degree of left ventricular dysfunction. Echocardiography has been shown to be an excellent tool to quantify global and segmental left ventricular function. Global left ventricular systolic function is expressed via calculation of ejection fraction and cardiac output, while segmental left ventricular function is assessed by wall motion score index. In our laboratory, we attempt to calculate ejection fraction in nearly every case, regardless of the referral diagnosis. Programs are currently available which provide for online calculation of ejection fraction via tracing of the LV endocardium in systole and diastole, utilizing two orthogonal views of the LV from the apex. We still prefer to use the method described by Dr. Quinones and his colleagues. The bulk of the ejection fraction is determined from the fractional shortening of the square of the minor axis, to which is added the component for shortening of the long axis. In cases when the image quality is suboptimal, we provide a visual estimate of the ejection fraction after evaluating the LV from multiple tomographic views. We actually report a range, such as 40 to 45%. Stam et al. Compared echo-estimated ejection fractions to the ejection fractions calculated from contrast ventriculography. An excellent correlation was obtained, even when the images were suboptimal. Just as the echo ejection fraction is a powerful prognostic indicator for patients with coronary heart disease, Doppler-derived cardiac output is also predictive of outcome, particularly in the setting of acute myocardial infarction. Stroke volume and cardiac output can be calculated using simple 2D and Doppler measurements at various sites within the heart and great vessels. We have found the left ventricular outflow tract method easiest. You will recall from tape number 4 that the stroke volume is equal to the product of the time velocity integral in the LVOT times the LVOT area. Doppler-derived stroke volume and cardiac output determinations have been verified by several authors by comparison to measurements obtained invasively with thermodilution. This data was obtained by Dr. Rick Nishimura for patients in our coronary care unit. For years, we have utilized measurements of cardiac output obtained via a Swan-Ganz catheter for prognosis and for management decisions with acute infarction. This important parameter can now be measured non-invasively. Although important, calculations of ejection fraction and cardiac output are by no means sufficient for characterizing ventricular function for patients with coronary heart disease. Ischemia and infarction cause segmental changes, and global LV function can be left relatively unchanged despite significant alterations in segmental contractility. Therefore, we must also quantitate segmental dysfunction. Many different models have been proposed for dividing the left ventricle into segments, ranging from as low as 9 to as many as 20 segments. We utilize a 14-segment model, which we have found to be most practical. For this segmental analysis, the ventricle is divided into 3 levels. The papillary muscle is the important landmark. Its length defines the middle level of the ventricle. That portion of the ventricle toward the mitral valve is the basal level. And that portion beyond the base of the papillary muscle is the apical level. At each level, the ventricle is subdivided into segments. At the base and mid-levels, the segments include anterior free wall, lateral, inferior, inferoseptal, and anteroseptal. The base and mid-level therefore comprise 10 segments. The remaining 4 segments are at the apex: anterior, lateral, inferior, and apical septal. The septum is not divided in 2 at the apex because it is a short segment at this level, and also because the entire apical septum is usually supplied by the left anterior descending coronary. At the basal and mid-levels, the anteroseptal segments are supplied by the LAD, while the inferoseptal segments are supplied by septal perforators from the dominant vessel on the inferior surface. All 14 segments can be visualized using an apical transducer position. In apical 4-chamber format, these are the inferoseptal and lateral segments at the base and mid-levels. This is the apical septal segment, and this is the apical lateral. This segment is supplied by the LAD, while the basal lateral segment is supplied by obtuse marginal branches of the circumflex. The mid-lateral segment is supplied either by obtuse marginal branches or by diagonal branches of the LAD. Rotating to the apical long axis format, we now have the anteroseptal segments at the base and mid-levels. This is the anteroapical segment. These segments can be either inferior or lateral, depending on how far the transducer has been rotated. Rotating to the apical 2-chamber view, we are now imaging the anterior free wall at the base and mid-levels, as well as at the apex. These are all supplied by the LAD and its diagonal branches. This is the full length of the inferior wall, which makes this apical 2-chamber view the best for identifying inferior infarcts. The basal and mid-levels are supplied by the dominant inferior coronary artery, usually the right. The LAD wraps around the apex to supply the inferoapical segment. To calculate a wall motion score, each of the 14 segments is visualized from as many different views as possible. Each segment is assigned a score according to its degree of systolic thickening. In our earlier work, we used a score of 0 for hyperdynamic, but we currently assign a 1 if the segment is either normal or hyperdynamic. For mild or moderate hypokinesis, we assign a score of 2, 3 for severe hypokinesis or akinesis, 4 for dyskinesis, and if the segment is part of an aneurysm, it is given a score of 5. Once the segments have been scored, the individual scores are summed. This total is referred to as the wall motion score. This score is then indexed by dividing it by the number of segments visualized. Accuracy of this parameter is dependent on visualization of all segments, which should be possible in 95% of cases. Having discussed the assessment of global and segmental left ventricular function by 2D and Doppler echocardiography, we will now turn our attention to the important applications of echocardiography in the setting of myocardial infarction. In our coronary care units, echocardiography is utilized for nearly all patients admitted with acute myocardial infarction. Echocardiography is an ideal tool in this setting. It provides tomographic images of the ventricles in real time and this important information is obtained non-invasively. The studies can be easily performed at the bedside, and the cardiologist is provided with immediate feedback about the structure and function of the heart. Furthermore, echocardiographic studies can be repeated in serial fashion as often as the clinical situation dictates. As we focus on the use of echocardiography in the coronary care unit, we will first demonstrate echocardiographic localization of infarction, and at the same time illustrate how echo is used to determine the extent of infarction. We will then discuss the utility of this echo data for making acute management decisions. Finally, we will discuss the echocardiographic diagnosis of the mechanical complications of myocardial infarction and utilization of echo in the differential diagnosis of myocardial infarction. As in previous tapes, pathology slides have been provided by our cardiac pathologist, Dr. William Edwards. With acute myocardial infarction, regional analysis of the left ventricle is crucial. The infarct can be localized by identifying the abnormally contracting segments, and the score index will serve as an estimate of the infarct size. These short-axis pathologic slices demonstrate regional involvement typical for a large anteroseptal apical infarct. All of the apical segments are infarcted. Moving toward the midventricular level, we note infarction of the lateral, anterior, and anteroseptal segments. And as we move to the basal level, there is involvement of the anterior and anteroseptal segments. This infarct resulted from occlusion of the proximal LAD. Regions of chronic infarction become thinned and fibrotic, and therefore well demarcated from adjacent normal myocardium. This pathologic specimen has been sectioned in long axis. This patient had an old inferolateral infarct involving the basal and mid-levels. Note how easy it is to identify the chronic infarct because of the thinning. This 80-year-old female had a long history of hypertension. In this apical long axis view, the anterior septum is hypertrophied. This is the inferolateral wall, which is relatively thinned and echodense due to an old scar. Note the akinetic inferolateral wall and the normally contracting septum. Rotating to the two-chamber view, the anterior free wall is hypertrophied, as is the papillary muscle. The underlying inferior myocardium is infarcted, and hence thin and akinetic. In apical four-chamber format, it is apparent that the lateral wall has also thinned at the base and mid-levels. Based on all views, the wall motion score index calculated to be 1.9. In contrast to chronic infarction, this patient expired with an acute inferolateral infarct. This is a hemorrhagic infarct, and we are able to identify the extent of the infarct by the deep red color. However, note that these walls that are acutely infarcted have not thinned. In fact, the walls appear edematous and thickened. In comparison to chronic infarcts, this feature makes acute infarcts more difficult to identify by 2D echo. In diastole, acutely infarcted segments will often not be apparent because they remain identical in thickness to the normal segments. However, in systole, little or no thickening will occur in infarcted segments, in contrast to normal systolic thickening of non-infarcted segments. The assessment of systolic thickening is best made when the entire width of the segment is visualized, from endocardium to epicardium. Traction by neighboring segments can cause the infarcted segment to move inward in systole, And if one only paid attention to endocardial motion, one might get a false sense that the segment is contracting normally. However, if you view the entire width of the wall, it will be obvious that it does not thicken from diastole to systole, even if some inward motion occurs. This patient has an acute inferior infarct. In this diastolic frame, note that the inferior wall still appears normal in thickness compared to the septum. Now, in systole, it is obvious that the septum has thickened normally, while the inferior wall has not changed in thickness. In real time, the lack of systolic thickening is obvious. This is a parasternal short-axis view of the left ventricle. This is the inferior wall and overlying posteromedial papillary muscle. In systole, the septum and anterior wall have thickened. The transducer has been tilted slightly to separate the papillary muscle from the underlying inferior wall segment. The inferior wall is thinner in systole than it was in diastole. This dyskinesis will be more apparent in real time. Since this patient also had hypokinesis of the lateral wall adjacent to his inferior infarct and akinesis of his inferior septum, his wall motion score index is 2.0. This patient was admitted with an anteroseptal apical infarction. Although the septum has not yet completely thinned out, it bulges toward the RV. This represents infarct expansion. In real time, note that the basal septum and inferior wall at base and mid-levels contract normally. The infarcted segments, including the infraoapical, are dyskinetic. This is the apical four-chamber view from the same patient. The lateral and infraoapical segments at base and mid-levels contract normally, while the apical septum and apical lateral segment are mildly dyskinetic. The transducer has now been rotated to the apical long-axis view. This is a Swan-Ganz catheter in the right ventricle. The basal anterior septum contracts normally, and the infralateral wall contracts vigorously at the base and mid-levels. The apex is mildly dyskinetic. The transducer has been further rotated to the apical two-chamber view. This is the descending thoracic aorta. In real time, the inferior wall will contract normally at the base and mid-levels. The anterior wall and the infraoapical segment will be markedly dyskinetic. Remember that the LAD not only supplies the anterior wall and anterior septum, but also usually hooks over the apex to supply this infraoapical segment. Based on all views, the score index for this large anterior infarct is 2.4. This patient has a known occlusion of the circumflex coronary artery and a resultant lateral infarct. Here the four-chamber view has been tilted slightly to optimize the image of the lateral wall. The lateral wall is akinetic at the base and mid-levels. The lateral infarct is also apparent on this apical long-axis view. This patient also had infarction of the adjacent inferior wall. The wall motion score index was 1.7. This is the same pathological specimen we viewed earlier, demonstrating the acute hemorrhagic inferior infarct. This infarct not only extends to the adjacent lateral wall, but also involves the inferior septum and the inferior wall of the right ventricle. Right ventricular infarction is found in up to 40% of inferior infarcts, and it is mainly found in those inferior infarcts that have inferoseptal involvement. This is the patient we presented earlier with acute inferolateral infarction. With every inferior infarct, the echocardiographer should pay particular attention to the inferior septum and the inferior wall of the right ventricle. The anterior septum demonstrates normal systolic thickening, while the inferior septum is akinetic. Still in parasternal short axis format, we have tilted the transducer to focus on the RV inferior wall. In real time, vigorous contractility of the RV anterior wall will be apparent. Although this pulls the RV inferior wall inward in systole, you will see that there is no change in thickness of the RV inferior wall from diastole to systole. This is an acute infarction of the RV inferior wall. It is important to recognize RV infarcts since they can cause hypotension, and therapy involves infusion of saline, which is opposite of the therapy for cardiogenic shock secondary to LV failure. This patient presented with an inferior infarct by ECG criteria. The right ventricle is enlarged. In real time, abnormal septal motion will be apparent. This is due to RV volume overload. Note the normal global LV function. In parasternal short axis, marked right ventricular enlargement is apparent. There is thinning of the inferior wall and inferior septum. In real time, these segments are akinetic. This apical four-chamber view is modified to focus on the huge right ventricle and right atrium. Because of marked RV enlargement and dilatation of the tricuspid annulus, the tricuspid leaflets do not coapt in systole. A pulsed wave sample volume has been positioned on the atrial side of the tricuspid leaflets. The spectral display shows an early diastolic velocity of 0.7 meters per second. The tricuspid systolic signal is completely laminar. This low velocity, laminar signal is due to severe tricuspid regurgitation. Did you notice the low velocity signals below the baseline that precede the QRS complex? This is diastolic tricuspid regurgitation, which gives witness to the marked elevation in RV diastolic pressure. Marked tricuspid regurgitation is confirmed by color flow imaging. The regurgitant jet nearly fills the huge right atrium. We have now illustrated how echocardiography can be used to determine the extent of ventricular dysfunction with myocardial infarction. In the acute setting, this usually provides a slight overestimate of the infarct size, since some of the abnormal segments can be severely ischemic or stunned rather than infarcted. Nevertheless, the wall motion score index is an extremely important parameter which demonstrates the extent of abnormally contracting myocardium, and the degree of segmental dysfunction provides vital prognostic information. Obtaining this assessment of prognosis at the time of admission allows us to more rationally triage patients and also serves to supplement the ECG when the patient presents early enough to be considered for acute intervention. There are currently 5 major studies in the literature involving a combined total of more than 600 patients that investigate the utility of echocardiographic scoring of wall motion at the time of admission for acute myocardial infarction. These studies use different scoring systems. Nevertheless, all have shown that echocardiographic wall motion scoring provides useful prognostic information for in-hospital complications. Dr. Nishimura's article details our early experience with the wall motion score. He performed 2D echoes within 12 hours of admission on 100 consecutive patients admitted to our coronary care units to rule out infarction. 61 of these patients were later diagnosed as having acute infarcts based on standard criteria. When these 61 patients were grouped according to complications, it became apparent that those with a higher score index had a significantly higher chance of congestive failure, ventricular tachycardia or fibrillation, or in-hospital death. A wall motion score index of 2.0 tends to separate those who are at high risk of experiencing these complications from those who are at low risk. Dr. Kan and his colleagues in the Netherlands used echocardiography to obtain wall motion scores for 345 patients shortly after they were admitted with acute myocardial infarction. They utilized a different convention for scoring wall motion, which explains why the scores which they reported differ greatly from the score indexes which we have utilized. Nevertheless, the basic principle holds that higher wall motion scores are predictive of complications. For patients dying during the first year after infarct, including in-hospital deaths, the mean wall motion score was 16.2. The mean wall motion score for survivors was 5.7. For the patients dying in hospital, there was a significantly higher mean wall motion score, 19.2, for those patients with severe pump failure, compared to the mean score of 13.5 for those patients who expired with cardiac rupture. And note that the mean score for patients with free wall rupture was significantly higher than the mean score for patients who died with ruptured papillary muscles or septa. These authors selected a cutoff value of 10 for wall motion score and analyzed the accuracy of a score greater than 10 for predicting death during the first year following infarction. The predictive accuracy of a positive result, that is, of a score greater than 10, was 61%. The predictive accuracy of a negative result was 97%. Each of the 5 studies which we previously listed showed a similar high predictive accuracy for a low wall motion score. This allows us great confidence in triaging patients with acute infarction and low scores to short hospital stays. We will now return to Dr. Nishimura's study to further illustrate the utility of wall motion scoring for triaging patients with acute infarction. The cardiologists caring for patients in this study assigned to each a clinical Killip classification without any knowledge of the echo results. As you can see, 14 patients were Killip class 2 to 4, and as expected, these patients had wall motion score indexes of 2 or greater. This study was performed before the advent of acute interventional therapy, so it is not surprising that these 14 patients remained in an abnormal Killip class throughout their hospital stay. When considering triage, it is of more interest to consider the 47 patients who were assigned an initial Killip class of 1. On clinical grounds, these patients would all have been candidates for early ambulation and early discharge. However, note that 10 of these patients deteriorated to a higher Killip classification while in hospital. And the wall motion score index, obtained by echo at the time of admission, was significantly higher for those patients whose condition deteriorated when compared to the score indexes for those patients who remained clinically stable. Once a patient has been admitted with myocardial infarction, the echo-derived wall motion score index is one of the major factors we use to assign a specific rehabilitation protocol. Since the wall motion score index helps to fully define the infarct patient's risks, it serves as a backdrop not only for triage decisions, but for a wide variety of clinical management decisions that are made throughout the hospital stay and beyond. None of these decisions is more important than that regarding acute interventional therapy. Intravenous thrombolytic therapy has become the standard of care for infarct patients who present early enough and who have large enough infarcts to warrant the risks, and who have no definite contraindications, such as a recent bleeding ulcer. The GC trial, performed by an Italian study group, has served as a landmark in supporting the use of thrombolytic therapy. More than 11,000 patients with acute infarction were randomized to intravenous streptokinase versus standard therapy, and a statistically significant reduction in mortality was observed for the streptokinase group. In this study, as in most of the major studies that have recently been conducted to investigate the efficacy of acute intervention, electrocardiographic ST segment changes were used as a major admission criterion. However, not all patients with new ST segment shifts have enough myocardium involved in the acute process to justify the risk of thrombolysis. For instance, this is the GC data broken down according to ECG localization of the infarct. You will note that for inferior and lateral infarcts, the mortality data was not significantly different for the patients who received streptokinase compared to the controls. As an example, this is the ECG of a 38-year-old patient who presented to the emergency room after several hours of severe chest discomfort. There is anterior T-wave peaking with ST depression in the apical leads, and ST depression and T inversion inferiorly. There is also 1 millimeter of ST elevation in lead L. Echocardiography was performed in the emergency room. There is akinesis of the apical septum with normal global function. This was the only abnormal segment identified. His wall motion score index was 1.1. With this small amount of myocardium involved, we decided against thrombolytic therapy. He stabilized with nitrates and a beta blocker, and his enzyme rise was small. He subsequently underwent elective coronary angiography, which identified a 90% mid-LAD lesion and a 60% lesion in the distal LAD. These lesions were successfully dilated. His predismissal LV ejection fraction was 70%. In this case, echocardiography gave us confidence that we could withhold thrombolytic therapy and that we could proceed with angiography on an elective rather than emergency basis. On the other side of the coin, ST segment changes on the ECG may not be impressive even though a large amount of myocardium is involved in the acute infarction. This data was obtained by Dr. Blank and his colleagues at Mount Sinai in New York. 152 patients underwent coronary angiography within a mean of 6.3 hours after the onset of infarction. ECGs were obtained within 1 hour of the angiographic study. Note that a significant percentage of patients occluded a coronary artery and infarcted without any classical features on the ECG. Hence, it is quite possible for the clinician to be misled by the ECG into underestimating the extent of an acute infarct, which might inappropriately lead to withholding thrombolytic therapy. This is the ECG from a 67-year-old male who presented to the emergency room with several hours of severe chest discomfort. He had never had any prior episodes of chest discomfort. The tracing shows first-degree AV block and low anterior forces, but does not show any impressive repolarization changes. Echocardiography was performed in the emergency room. This is the peristernal long axis portion of the exam which immediately tells us that there is a large septal infarct. There is severe hypokinesis of the anterior septum, including the basal segment, which correlates with severe stenosis or occlusion of the proximal LAD. His anterior wall and apex were akinetic, such that his wall motion score index was 2.1. Because of the benign appearing ECG not meeting standard criteria, the clinician decided against thrombolysis. Serial ECGs were essentially unchanged, but his creatine kinase rose to about 5 times normal. At cath, occlusion of the proximal LAD was noted, and his ejection fraction was 27%. The ECG is usually useful for determining the acuity of infarcts. Through the years, the ECG has also served to provide useful clues to the extent of myocardial involvement. Echocardiography directly visualizes the myocardium involved in the acute infarction. We are trying to salvage myocardium, not ST segments. Therefore, it makes sense to make our management decisions during acute infarction with full knowledge of global and segmental LV function.